And I know the recovery process was like 650 some days. He underwent 17 some surgeries, and you were, the lead physician on that. And I wanted to kind of ask you, like watching the documentary, I was kind of like, it was mind blowing just to see it. But you were there, you were in it, and I wanted to ask you kind of what your experience was like, kind of working through Alex through all that. Hey guys, I have a very, very special guest today. I have Dr. Robin West, who is a world-renowned orthopedic surgeon at Anova. She is also the lead team physician for the Washington Nationals and the head team physician for the Washington football team. She also serves on the board for directors of the NFL Physician Society and the NFL Scouting Medical Committee. Dr. West was also the lead physician on Alex Smith's injury, which some of you may know about and which we will be discussing later on. I actually highly recommend watching a documentary for those of you who haven't. It is not for the faint of heart, so please make sure that if you are freaked out by blood and things like that, don't watch that. But also, lastly, Dr. West is actually my surgeon for my ACL that I had done about 8.5 weeks ago. Welcome to the show, Dr. West.
Thank you so much for having me, Wesley.
Cool. I'm excited to kind of dive into the different topics. Some of the questions that we have are actually from people from social media who are interested just to hear your perspective on certain things, particularly around the ACL rehab, which we'll discuss kind of later on. But Dr. West, can you just tell us a little bit about yourself, kind of your schooling, your residency, and your specialization?
Sure. So I'm from Southern California, actually. I grew up in Santa Monica, and then I went to Johns Hopkins for college, and then George Washington University for medical school. And then it was actually in college, I decided to become an orthopedic surgeon. I had swam competitively throughout high school and in college, and I got mononucleosis while I was in college. And I had an enlarged spleen. And so our team physician wouldn't let me swim anymore. So I got to work in the athletic training room and become a student athletic trainer that season. And that's when I got to really work with the athletes and work with the team physicians and got to watch some surgery. And I decided I wanted to go into orthopedics. So I went to medical school with that plan. And I loved everything about it, but I wound up doing orthopedics and did my residency at George Washington University. And it was there again, I loved everything about orthopedics. I loved trauma surgery. I loved the arthroplasty, but ultimately I chose sports medicine. And then I did my fellowship at the University of Pittsburgh. And
Cool.
I think I chose sports medicine because it's fun to work with athletes of all ages and abilities and to really kind of challenge yourself and you can take care of whole families, the little league athlete to the mom who's a weekend warrior to the grandparent who tears her rotator cuff. So having that whole broad range was what ultimately made me select it.
And I'm sure at this point you've probably seen some parent-children combinations before, maybe
Lots
even
of
like,
them. Yes.
yeah, back-to-back appointments and everything like
I
that.
have.
And I know you do specialize in knees, which is obviously why I selected you for my surgery and everything like that. But I kind of want to ask you, like, what led you to specializing in knees?
I actually specialize in a lot of things, Wesley. So I sports medicine, I take care of everything really. So when you take care of a team, you've got to be the doctor of all trades. So you do have to have a understanding of the non-operative, the primary care management, as well as all joints. So I take care of all injuries non-operatively, and surgically, I take care of shoulders, knees, and ankles. Those are my main things. We all sort of specialize. I mean, at this point, everyone typically, when I was training, we did everything. We did a little bit of spine, you did arthroplasty, but now people have become more and more specialized. So knees and shoulders are obviously the most common injuries that we see. Typically, I take care of a professional football team and professional baseball team. So those are our most common injuries.
Cool. And a question that I actually had for you is like, how did you get to this point in your career today? Like, obviously, you're very well respected, you're very well known, and on top of that, you're working with professional athletes and professional football teams and baseball teams. Like, kind of like, what was your path, and how did you get there to where you are today?
At the University of Pittsburgh, I got to train taking care of high school athletes, collegiate athletes, and professional athletes. And when I was finishing my fellowship, my chairman asked me to stay on as faculty at the University of Pittsburgh. So it was there that I accepted that job. And then I was asked to be an assistant team physician for the Pittsburgh Steelers. And then the head team physician for Carnegie Mellon University and University of Pittsburgh. So I got a lot of great opportunities there. And, at first I was really interested in just taking care of my everyday athlete and just being sort of the everyday orthopedic surgeon. But then these opportunities come kind of at this crossroads of hard work and an opportunity, and you've got to jump on that when it's available. So I was lucky to be around that time, especially with the Steelers. I was there for 11 years with them as a team physician, and we had a big run. We went to 3 Super Bowls and had a lot of success there. And so that was a really unique opportunity for me, just being part of that and seeing teams, from the good to the bad and experiencing these highs and these lows. And then Anova recruited me back in 2014 to come and to build their sports medicine program. So at that point, it was a point in my career where I felt like I had done a lot, and I wasn't really looking to leave, but it was an opportunity to start from the ground up, to start from ground zero and to build something new. And I had young kids, and I thought either I do it now or I wait until they're older and do it. So I jumped on that opportunity.
And as a follow-up, like how has that process been as far as like, at Anova, you've been there for, about 6 years now. Like how has that been building that up? Because obviously I've seen the facility and everything like that. And it's phenomenal what you guys are doing. And what was that experience from, kind of this past 6 years building that up?
Yeah, it was something very different for me. I never had to run anything before or manage people. And so, and again, I came and there was nothing. So it's kind of fun to build a team from the ground up and handpick people. And so we've really made a multidisciplinary team. That was my goal, to come and to make it comprehensive, where we have the primary care sports medicine physicians, orthopedic surgeons, athletic trainers, physical therapists, strength and conditioning coaches, neuropsychologists. Everyone works together, nutritionists, sports psychologists too. Those are all big parts of it. So it's kind of a one-stop shop where you can come in and you can get everything that you need. And so they've been very supportive of us building it. And the teams approached us my first year here as we were building it, because they were looking for the same kind of comprehensive program. The Nationals were looking to really look at injury prevention and really put a big focus on that. They had a lot of injuries before, over the past few years before approaching us, and that's what kind of led to this partnership. So that's how that started. And same with the Washington football team, on let's focus on the whole athlete and not just on, okay, let's fix their ACL tear after they get injured, but let's try and focus on prevention and then recovery and performance.
Yeah, that's awesome. And a plug for you, Dr. West, is the fact that you and I have co-treated probably like a handful of patients by now, and hopefully many more to come in the future. And I can say for certain that without it, and I've worked with many other orthopedists in the past before, and I think that's something that stands out about you. And also, it's not just me conveying this; all my other athletes have conveyed this as well. Is the fact that you take the time to listen. And like I worked at places where a lot of people will say that kind of maybe the typical thing that you've heard is like, oh yeah, I saw the doctor for 5-10 minutes, and that's not just with orthopedic physicians as well, but also even on the PT side, where a lot of times like patients don't even feel like they're being heard. They'll be like, oh yeah, I saw them for 10 minutes or maybe even 10 minutes, and then 5 minutes out the door, and then that's it. But something I really appreciate the fact is your communication. I've had several cases where I've like texted you the day of, and then you've been able to somehow squeeze them in. I don't know how you do it, but you somehow squeeze them in. And it's been amazing. And the fact that I hope that you understand that, like for me as a clinician and also as your patient, and all of my other athletes, like we generally do appreciate what you've done. And it's in my opinion what I believe is the highest level of care for someone of your in your position. So hopefully for those of you guys who are listening that are PTs and things like that, try and find an orthopedist in your area like Dr. West who you can communicate with. And luckily now at this point with Teddy and I and Sweezy, that we've been able to find a handful of doctors that really value what we do from the PT side, and also we can directly communicate with on the physician side and orthopedic side. And I think that that's the biggest thing that I hope that maybe the younger clinicians are starting to understand, is like communication and a team effort is absolutely the number one key in any type of rehab. So that's a little plug in the middle of
Wesley,
this.
no, it's sorry. It's really true. Honestly, that's the most important part, I think. I always joke around, athletes are like, oh, thank you so much, I'm back to doing whatever. And I said, okay, I did your surgery for an hour and a half. And that's all I did, my little part. And then they and their physical therapist then did the rest. And so having somebody like you as well, having somebody to listen and to really try and fine tune it and to work with them, that it's a huge thing. So it's a team. It takes a team. It's not just one person as part of it.
Yeah, definitely. And this next question is selfishly a little more from my point of view, because my question that I had for you is, we talked about how you were featured very much, obviously, with Alex Smith in that documentary. Also, for those of you who don't know, the documentary is called Project 11. It was done by ESPN, a very well done documentary that kind of just portrays Alex Smith's recovery process from the day of his injury all the way through to getting back on the field again. And for those of you that don't know, he actually won Comeback Player of the Year, which is probably a phenomenal story, even from your perspective of seeing that and
Yes.
literally seeing it on the field. And for those of you who don't know, he suffered and please correct me if I'm wrong, Dr. West, he suffered initially a tibial fracture on the field November of 2017,
18,
18,
2018.
2018. And the recovery process was like 650 some days. He underwent 17 some surgeries, and you were, the lead physician on that. And I wanted to kind of ask you, like watching the documentary, I was kind of like, it was mind blowing just to see it, but you were there, you were in it. And I wanted to ask you kind of what your experience was like, kind of working through Alex through all that.
Yeah, so it happened on November 18, 2018. It's burned in my brain. But yeah, he had an open tibia fracture. So an open fracture obviously means that the skin's broken, the bone sticks through the skin, on a dirty field, which is a bad sign, right? So that's coming into it, he has a very high risk for infection, which is why you have to rush to get to the operating room. So we got to the operating room quickly. Within a 2-hour period, he was in the operating room and having it cleaned out and fixed. And unfortunately, he did suffer an infection at that point. So the 17 surgeries were that initial surgery, and then the rest were all to debride the wound, basically, because the infection became so severe that it was a flesh-eating bacteria, necrotizing fasciitis. So he almost lost his leg that first week. But we went to the operating room every day and just kept on working away and trying to save it and clean it. And then we ultimately wound up doing muscle transfers and covering the wound, because by the end, as you saw in Project 11, he had nothing left, right? He had just his bone of his leg. So we had to flap his muscles around and get coverage for it. So luckily I had a terrific team, trauma surgeon and plastic surgeons, and they're, great guys. So, but you know what, it was our work, obviously. I mean, we were the ones behind the scenes doing that work, but again, it was his fortitude and his wife's fortitude and family, the support that he got, and his grace. I mean, that having someone who's going through all this and who just takes it every setback. You talk about setbacks and recovery, one step forward, 2 steps back, and that was the whole thing. But everything that he had, every challenge he had, he always said, okay, what's my next thing? What am I doing next? So when he is going through this limb salvage type thing, he's in this external fixator on his leg, and initially it went from his thigh to his foot. So he couldn't bend his knee, couldn't bend his ankle. I mean, it's miserable. But he kept saying, okay, so what's my next step? Your next step is going to go to a shortened external fixator. It's going to go from below the knee to your foot. And then it's going to get shortened a little more. And then it's going to be this. And so every step, and he just said, okay, 2 months, I'll do that. Okay, 3 months, I'll do that. And sometimes it became 4 months or 5 months, but ultimately 2 years later, it was interesting. So actually very early on, I reached out to my friend at the Center for the Intrepid, Johnny Owens. He's a physical therapist there. And I reached out to Johnny and said, I may need your expertise at some point, because we're either going to save his leg or we're going to amputate his leg, and he's going to have deal with an amputation or a limb salvage. And so I said, Johnny, at some point I'm going to need your services for one or the other, whatever we do, and I'm going to want your help on the rehabilitation side. And so we started that conversation early. So we brought Alex to Center for the Intrepid about 4 months. I think it was about 4 months after his injury. And so it was that first day, he hadn't talked about football at all. He had no interest. So he was just trying to recover, right? And trying to get through all this. But as we left the Center for the Intrepid, as we're walking out in the parking lot that night, he said, he finally asked me when I was going to let him play football again and what it would take for me to clear him to play football, right? So this year he, early on in the spring, he was kind of nudging me and saying, hey, are you going to clear me? When am I going to get cleared? And there were a lot of things that have to go into that, a lot of thought. You have to look at the bone, is a bone totally healed? Is it healed enough that he can play? Because a lot of times these bones don't heal completely, but what's enough? Is the soft tissue healed enough? Does he have the strength? And again, I can clear medically, I can clear somebody, but it's really the coach's decision. Is he going to make the team? Does he have the functionality to function, to return to play on the football field? So it's a combination of physical therapists, obviously, being involved, and strength and conditioning coaches and the regular coaches. But I never worked with someone like that. And somebody, these players all say, "Oh, I'm a mental fortress. I've got such strength," and but he truly does.
Yeah, and I'm sure I remember vividly myself his first game back. He probably wasn't supposed to play that game, but then the starter obviously went down, and it was against the Rams, if I remember correctly. And the probably arguably the best defensive player in the league decides to sit on him and get on his back, and I'm sure that that was a roller coaster ride for
Oh,
you.
it felt like it was like an hour long. I watched it in slow motion. He jumped on his back, and then Alex is standing on his one leg, on his right leg, and I thought, "Oh my, I can't believe this is happening." And then he got right back up.
Yeah, I'm sure that at
Yeah.
that moment you're probably like, okay, I think everything's healed at this point. Considering
Everyone was texting, the whole medical team, all the trauma surgeons were like, "Oh, he did it," and
yeah,
Alex's wife, and yeah.
and they showed his wife on TV, and it was just like
Oh,
I like felt like I was like with her and like experienced everything she felt, and I couldn't imagine what it was like to be see that from like a spouse perspective. But honestly, what a crazy story for him, and an amazing story that I'm sure that this would probably be something that you will remember for the rest of your career as a physician.
yeah, again, it portrays that whole team approach, right? Because no one, I mean, everyone had to be involved. We had to get every single person involved to make this decision, and to work with him and to get him back to where he was, and working with his wife also, right? She had put so much into it herself for 2 years, and but at that point, she was ready. She's like, I this is what he wants to do, and this is what he needs to do. He wants to go to the peak and try and reach it as if he can, and if he can't, he's fine. If he can't get there, and someone says you're not able to do it, you can't protect yourself, you don't have the ability to play anymore, he would be fine. He said, I can walk away from it, and she was fine with that too. But he wanted to try at least.
And he did well, obviously. And I've obviously even seen some people's like petitioning to change the award to be named after him. I was like, that would be obviously an amazing feat for him.
Yeah,
It's just I've thought about like what it would be like if, and I'm going through my ACL rehab process and things like that, and it's like, what was it like for him as a professional level athlete, 600 plus days of just rehab and surgeries, and then finally to make to the point, and your first day back, you have this 300-pound plus person sitting on you, and I'm sure that for him it was regardless of mental fortitude, that had to have like at least freaked him out to a certain extent. But obviously he played, and he played well for the entire season, and he was one of the main people that led us to the playoffs and everything like that. So I say
yeah.
us just like I'm part of the team,
Right.
but
No, it's so true. It's true.
yeah,
And that first hit, I mean, that first sack, obviously he came off and he had this huge smile on his face. And I was like, "What, Alex?" And he said, he goes, it's off. It's finally, that like whatever monkey on your back, right? It's finally did it. And
yeah,
I got there.
yeah. That's a
So,
very
and
cool
obviously it was
thing.
a bad game with the mud and the rain. And I'm like, this is like the worst game to get back to.
And to play Aaron
Right.
Donald, of course.
Yeah,
Um,
exactly.
and I also wanted to ask you kind of just what it's like working with professional level athletes. You're on TV. They kind of pan you sometimes when a player gets hurt, and then they're kind of like, "Oh, this is Dr. Robin West working with the athletes." And then I forgot what it was. There's one of the games where the quarterback got hurt, and then you guys you're checking him out on the sidelines. You're kind of reaching under his pads, and obviously it's super hard for you to actually properly assess it. And I remember you like sprinted back, and then all that kind of stuff, and then you did something in the back, and then you brought her back. So I kind of just wanted to like get your thoughts as to what that's like. Your heart has to be like kind of rushing at the time because he was a starting quarterback, and they were like, got to get him back in and things like that. Like, what is that like?
Yeah, I mean, you have to be fast thinking, especially during a football game, right? During baseball, it's a little different because a guy will get injured. We have some time. It's very different paced. But during football, we like that incident where we have to get back is, figure out make a diagnosis. Is he safe to return to play? And is there something little I can do to help him? Whether, I can bring him back with an athletic trainer. Can we retape him, put some pads on, do a little local injection? People always say, "Oh, you're giving him oxycodone." No, I'm not giving him any narcotics or pain medicine like that, but we can numb an area if it's a very superficial bruise or, an AC joint injury, something like that. So those are simple things. And if he's safe, if I deem him safe, he's got good motion and good strength, then we're good to come back. So those are things you've got to think of quickly, especially under the bright lights and the loud noise and television cameras in your face.
Yeah, yeah, and it's obviously probably very like I don't know. I guess for putting myself in the situations, it's kind of nerve wracking just because you have to make this impulse decision, not impulse, but like well thought out. But it's like you said, it's timely, especially if it's like a high profile person in a playoff game, and like you said, so many other stresses that come into play that you as the lead physician have to make that decision relatively quickly in a timely manner, because it could be the difference between a drive having that player or not having that player for the drive. And sometimes we know in football, the one score can be the game changer
Change
for
the
everything.
Yeah, I mean, I think that the most important thing, and I learned this early on, is to never focus on anything else but the player. Just like, okay, this is what I have to do, and so I kind of close everything else out. And people always say, like, oh, I bumped into the camera. I don't even like pay. I don't even know what's around me. I'm just on a player, trying to think about realistically, what is this? What's the injury? Is he safe? Can I get him back again? And it's tough, especially in a big game. You have a playoff game or something like that, right? And all of a sudden, you feel the pressure of the coach, like, hey, we need this guy back, but you have to have the strength to say no, and that's not safe. And so I always keep the players' best interest in mind. And sure, you can be a fan as a team physician, but that's the last thing that I am.
Yeah, that's awesome. Definitely appreciate you kind of sharing, two very unique perspectives. Obviously, relating to the Alex Smith, but also dealing with professional athletes, because I think that that's a goal for a lot of people, whether it's PTs, physicians, or anything like that. Like, a lot of people want to work with professional athletes, but at the end of the day, they're a different breed. They're very unique people. They're driven, they're motivated, they're hard workers, and all that kind of stuff. So it's kind of a unique environment for people to work in, and I'm sure that people kind of learn a lot from your experiences. And just to kind of shift a little bit, because I can't go full podcast without talking about ACLs, of course. I wanted to ask you, what is your typical graft preference? And this is not just me. A lot of people, this is probably one of the most popular questions that people ask is, what is your graft preference and why?
Okay, that's a tough question. I do lots of ACLs, and I'll tell you, my graft preference is an autograft. Is always going to be your own tissue. If you just look in the literature, allografts, especially for people under the age of 25, has a 25% failure rate. So the majority of ACLs I'm doing are younger people, but even on my older athletes, I prefer autograft, because we know that allografts take longer to heal, to become, biologically incorporated in the bone, to go through that ligamentization process, which is the maturation of the graft. So allografts can take in the lab 14, 16, 18 months. So if you're trying to get back to your sport and you have an allograft, there's a much higher chance of failure early on. So autograft is. So then we have our three autografts. Basically, we have our hamstring, patellar tendon, and quadriceps tendon. I'm a fan of them all. Actually, I do mostly patellar tendon and quadriceps tendons just in my practice, just because of the athletes I take care of. But that being said, I still will select a hamstring for some people. And the reason I'll select certain grafts is there are a lot of things to consider. I look at the patient size, because we have to look at, how do we accommodate their anatomy? So I often measure the footprint on the MRI. I'll measure their tibial footprint and their femoral footprint, and to see how large that footprint is. What graft can I use to accommodate that? When you look in the lab and you look at strength testing, the quadrupled hamstring, so taking the two hamstrings and quadrupling them, it's the strongest graft. So people say, well, why don't you use that? Why would you use patellar tendon? But the fixation is what is the weakest link for any graft. So if we're going to use a screw or we're going to use a button, that's the weakest link. So we have to think about that also. So, but somebody who comes to me with knee pain, they've had patellar tendon pain, jumper's knee or something like that, I don't want to take their patellar tendon. I don't want to aggravate that, right? So I'll think about using their quadriceps tendon or their hamstring. I don't like using hamstrings in girls, because we know that females have a higher chance of ACL tears. And the reason why is, one of the reasons is a quadriceps dominance, right? Females are more quad dominant. They have weaker hamstrings. So for me, taking a hamstring from a young female is what is not my last choice, really. And I find that a lot, because it's a small incision. So a lot of girls wind up getting a hamstring. But if you look at the literature, especially in soccer players and high school and collegiate female soccer players, they have a 28% chance of tearing their ipsilateral or their contralateral ACL in 2 years. So for me to compromise them and take their hamstring, that would be my least favorite graft for them.
Yeah, a couple of big things that I think I really appreciate the fact that obviously your thought process behind a graft selection is very individualized based on patient size, sport, gender, all that kind of stuff. And I'm in full agreement with you that hamstring grafts for especially maybe adolescent females is my least favorite combination as well. We've actually, I mean, thankfully, we're lucky enough to actually only have two re-tears in the past 3.5, 4 years that we've been a PT clinic, which for us is really good.
That's great.
But they've both been younger adolescent females with hamstring grafts. And it's almost,
Hmm.
maybe it's just somewhat, I'm jaded by it because of these circumstances, because we don't want any retail rates, but that's
Yeah.
physically impossible. But it seems to be, in my experience, that like it takes so long to regain full hamstring strength between the two sides. And I've seen a lot of people, even, 9, 10 months out, they're still lacking some hamstring strength, particularly in my experience, actually at end range beyond like 90 degrees to like, 110 degrees, depending on how big they are. But
Yeah.
it seems to me like it takes a really, really long time to regain that strength. And I'm full agreement with you that that's my least favorite combination between all the variables that we've just talked about.
Yeah, that hamstring strength is significant. I mean, there's the literature supports it. That deeper hamstring, that deeper flexion angle is where you lose your strength, right? So even for a sprinter, even somebody who's had some anterior knee pain, and I have a high level sprinter, I won't use their hamstring because for them to lose that last bit of terminal flexion strength is a big deal.
Yeah.
But if you think about it, I don't do it a lot, but a hamstring in a football player may be not a bad option. I mean, because again, they're not the quad dominant. They're typically not non-contact injuries. They're often contact injuries. But that's anyway. Lots of things go into it on picking a graft.
Yeah, yeah, and for any of you who are listening, whether you're a PT or a patient or anything like that, like make sure you're doing your diligence of making sure you're finding the right graft choice for yourself. It shouldn't be where, the surgeon is like, oh, this is the only one graft I do, so this is the only one you're choosing. Like it needs to be kind of an individualized process as far as selecting the graft goes. And this is actually exactly the conversation that Dr. West and I had when I was trying to choose between my graft. I obviously know the research and everything like that, and I went in. I was like, okay, definitely no hamstring. And then we were basically deciding between the quad and the patella tendon, which I was very comfortable with doing either one based on what I've seen from her for the patient that we've co-treated. And we ended up choosing the patella tendon because, Dr. West had asked me how I'd done the first time around on my right knee. And she was like, how did you do? I was like, I'm perfectly fine. I don't have any anterior knee pain. I can kneel on it perfectly fine. She's like, okay, well, you did well the first time. So let's go with what you know. So, obviously logically that made sense for me, but that might not be the case for somebody else. So definitely making sure you're asking questions as far as graft selection goes is extremely important. And Dr. West, this is a really popular question nowadays: is what are your thoughts on open chain exercises for ACLs? After we'll even go, yeah, obviously after surgery.
Yeah, so that's an interesting question. I always I mean the physical you obviously have the expertise more than I do. I do the surgery and then you do the rehab, but when I trained long time ago, 25 years ago, it was really a hot topic, and it was always that we were taught not to do open chain exercises post ACL reconstruction, at least for those first 8 to 12 weeks, because of that. Of the anterior force and terminal extension. So we were taught, okay, it's okay from 90 to 60, 90 to 40 degrees, but that terminal extension to avoid open chain. But I think the new literature and all the new research, biomechanical studies support doing open chain as long as it's not with a heavy weight, right? It's either, just your body weight or a very low weight early on. But I'm a big believer in focusing on everything, open and closed chain, and not just doing one or the other. And I think you and I've talked about it, Wesley. Some people really do well with one or the other. And so, but I like to mix it up. And so I am not opposed to doing it early on.
Well, that's awesome, and I think that that's something that's very, I guess, refreshing here because there's still, we get referrals from orthos from all over, and sometimes you look at the protocols and there's no mention of open chain. You're kind of like, am I allowed to do that? And then the patient will come in and tell me they're like, oh, my surgeon specifically was like, cannot do open chain, and then you're kind of like, okay, do I start the discussion or and that type of dialogue? Because then it's a referral source for us as a small business, which is something that we always have to take into consideration from kind of a business side of things. But at the same time, like I think that open chain is absolutely necessary at some point. And if, we obviously we want to be respectful of protocols and listening back and forth. But if someone's telling you that it's like, it's bad for you, it's dangerous, then that's kind of going beyond, that scope
Yeah.
of it. And if someone wants me to wait until 12 weeks, I'll be like, okay, yeah, no big
Yeah,
deal. I can wait.
it's probably worthwhile to reach out to that surgeon and tell them, because I think a lot of times we don't know the literature. So I'm always asking our therapist like, hey, what's new, or what can I do differently, or what is our protocol outdated, or because we have a protocol that may be around for a couple of years and it may not get updated. So for me, I actually like hearing from the therapist and saying, hey, this kind of is weird, that you're doing this, and um, and again, every surgeon has preferences. I allow weight bearing after a meniscus repair. A lot of people don't, but again, after I read all the research, all the literature, I'm like, there's no reason not to. It's for certain kinds of tears. And so I think that again, just having that communication, like you said, is key.
Yeah, and from a personal perspective, thank you for allowing me to weight bear 3 4 days after surgery because I don't I remember for my right one I was non-weight bearing for 6 weeks and
Oh,
I could not, it was so long ago, but trying to get up and down stairs is borderline impossible. Trying to take a shower, I pretty
so
much
painful.
just sat on the couch all day, playing video games and watching TV. But the fact that you are and all the research that I've read as far as like early weight bearing, like you said, it depends on kind of where the repairs and everything like that.
Mhm.
And I didn't have any pain when I was weight bearing. Like, yeah, there was some pressure just because my quads were weak and all that kind of stuff. But I was definitely very thankful to be able to weight bear some because I do think that it allowed me to go back to work sooner because I couldn't have imagined being non-weight bearing for 8 9 hours a day trying to navigate going to work and everything like that. It
Oh
makes it a little
yeah.
harder with the scooter and things like that. So I just from a personal perspective as a patient, that was definitely much appreciated. Uh,
Yeah.
Um,
Plus, your strength comes back sooner, right? I mean, I think you get your mobility back, and you get your proprioception back sooner. I
mhm.
think it just helps everything.
Yeah, definitely. And my final question for you, Dr. West, is regards to the return to sport process. Like, what does that look like for you? Like, are you communicating with the therapist? Are you involved in any sort of testing or anything like that? And what do you look for as a physician?
Yeah, I think for working with someone like you, Wesley, like I would just leave it into your hands. I just say, hey, let you do it. But I have a protocol that I have written up, just a basic testing protocol with like 5 various things. And I always tell the athletes it'll probably take you 6 to 8 weeks to get through this whole testing series. You'll go through one test, pass that, go through the next test. And I have this kind of generic one that I've worked on with some physical therapists. So I do like to be involved, but again, if I have someone like you who I'm very comfortable with, and I know that you're going to do it on your own, then I'm fine with you telling me, hey, listen, they passed everything, and or that I'm concerned about this or that. But if I'm working with someone who's not as familiar with it, or they don't do a lot of ACLs, and I take care of a lot of patients from outside the area, so I'm communicating from a far distance, and I don't always know what kind of care they're getting, then I'll give them the protocol and say, hey, listen, you've got to pass all these tests, and I want your therapist to write everything out for me.
Cool, awesome.
But it's a
Yeah,
huge thing. I mean, like you said, having only two re-tears, and it's a big difference. I mean, there's a lot that goes into the re-tear, right? It's a surgical technique, it's the graft, but it's the rehab is really the key.
yeah, and I'm a big fan of making sure that the testing needs to be pretty rigorous. I think the way that I typically will explain it, because I do have some people. I have like a close friend of mine who's a strength coach in Virginia. So he sees a lot of like soccer athletes, and if he has an ACL injury, like he can help with some of the rehab as far as the strengthening goes. But as far as the return to sport process, he doesn't want to be the one to make that decision, and he obviously understands he shouldn't based on his scope of practice. So he sends them to me. I'll like do the full my full like testing, which takes about 45 minutes or so. And then I'll send him back the reports. And unfortunately, I have made plenty of people cry because I'm just like, you're not ready. And I tell them at the end of the day, and I think almost living through it myself of going through, 2 ACL surgeries at this point, like I tell them like, I don't want you to end up like me. Like I'm 34 at this point, but I don't want you to go through 2 ACL surgeries. And, a lot of these kids are only 16, 17, 18 years old. They want to play college sports. And that's why I believe the return to sport process as far as testing goes needs to be very rigorous. It can't just be like I've seen some really bad ones where it's like, oh, you're doing just a single squat for like depth, and they're using a goney to measure how low you're going, and then um, if anything, maybe they might look at your jog a little bit, but it's like that can't just be it. It has to be very rigorous, or they only do the hop test. And like I utilize the hop test, but it can't just be one single test. It should be a full battery of testing. You should look at, like you said, the psychological side, because you mentioned that you have sports psychologists that you work with too.
Huge.
I'm sure you've seen like had you thought that, like, for example, like Alex, if you felt like he wasn't mentally there, like you can't go
He's not
back on the
ready.
field. Yeah.
No.
You can't. How is he going to mentally not be ready? And then a 300-pound lineman sitting on him, like that's not going to be a great situation, or he's not going to perform very well.
Yeah. It's a
It's a
huge part. That's a huge part. I mean, and no one talks about that really, right? No one, people forget that. And in our orthopedic literature, it's about a 65% return to play rate after an ACL. So even though the success of an ACL reconstruction is 85 to 90%, but the return to play at the same level you were at before is about 65%, whether you're a professional athlete, whether you're a collegiate or high school athlete. So it's very similar across all boards. But when you look at why, the reason probably 30% of them don't return, again, on most of these studies is a psychological. They're just not ready. They're psychologically, they don't trust their knee, they don't have the confidence. Is it because their knee doesn't feel good, or is it because they're just insecure about it? So I think that's a huge part. So I always try and get that early, try and pick that up on a patient early so I can get them working with someone.
Yeah, and I've had a couple of situations where I've referred out because I try to do my best to address the mental side where I've had some patients tell me that they've had nightmares, and it's like, okay, let's talk through what you felt and things like that. But that's obviously out of my scope of practice, where I talked about where my friend recognizes that clearing someone is not in his scope. So my scope is not sports psychology. Obviously I can talk about them, have them like tell me certain things, but if I feel like it's far beyond what I can handle or it's like too extreme, then obviously I need to refer out to a sports psychologist who is professional and can help them on a professional level too. And I think that no matter what the return, I think I did a poll just randomly on my Instagram just to kind of see where people were at and people who had underwent ACL surgeries. And as staggering of a statistic as it is, 2/3 of the people that voted had never even heard about ACL return to sport testing or never even underwent ACL return to sport testing. And that's a tragedy because you think re-tear rates now are 20 to 25% of people are suffering at re-tear rates. And out of those 25, like who knows how many go to suffer a third tear or a fourth tear.
Yeah.
And those are the ones where like, unfortunately, like I'm sure at this point you've seen in your career where it's like an 18, 19-year-old kid that has suffered 3 tears and it's like,
Yes.
I'm done playing sports. And that's tough to deal with.
Yeah.
And I as much of a dramatization as it may be, I say that ACL rehab is probably one of the hardest outpatient orthopedic things that we see. Because at the end of the day, you can screw up an ACL, like as far as the rehab goes. Like if you don't do a good enough job and they suffer a second, third, fourth tear, like in my opinion, you're kind of messing with this person's life. If it's
Mhm.
a grade 1 ankle sprain, a grade 1 muscle strain, like, regression to the mean is probably going to get better over time eventually.
Yeah.
Uh, but this injury, which I'm like, both of us are very passionate about, like it can change somebody's life,
Oh,
whether
yeah.
positive or negative. Thankfully for me, it was positive since it led me to this career. Um,
Yeah.
but we've had some kids who come into our facility, a healthy baller, like one girl in particular, she had 3 ACL tears before 18. She had goals of playing college soccer, and then she was like, can't do it anymore. So she just quit playing soccer. And it's a tough thing. I never work with her, unfortunately, but it's like, what if the rehab was different and things like that? And obviously there are
Yeah.
variables of just bad luck that does happen to some people.
Yeah.
It's a nature of playing sports and injuries, but that's kind of why I'm so passionate about making sure that the rehab is challenging and hard, in addition to the return to sport process being very rigorous, because you can't clear anybody before they're ready for it.
Yeah, I agree. Plus, that rigorous PT, I think, also helps with the psychological aspect too, because it just shows them, oh, hey, I got through this. Wesley told me it was going to be hard, and this testing was really hard, but I did it. And all of a sudden, they're like, oh yeah, I did that. And that's what I remember with Alex too. Every step he did, he's like, I did that. Like, I'm going to kick that out. I'm going the next thing. And so like everything that you do, it just helps to build the confidence. And so all around, I think that is the most important part.
Yeah, and as cliche as it is, the reason why testing is so important is because you don't want anyone guessing that you're ready to go back to playing a sport. And that's what, if no one is testing you, they're guessing. It might be an
Yeah.
educated guess based on certain things, but it's like these objective testing is like, okay, you are currently 82% quad strength, 84% hamstring strength, whatever it is of your other side. That way, it's this machine, this device telling you these consistent numbers that you can obviously retest a second time, as opposed to someone using their hands to be like, oh yeah, I think that's 80% or whatever it is. Like you can't do that. So
Hmm.
so I definitely love the fact that we're both pretty adamant about having proper return to sport testing, because that's what it takes to get clear, to get athletes safely back to the sports. And again, neither one of us for the rest of our careers are going to have no re-tears, because that's statistically impossible. But I think that between what we're doing as far as the rehab and like the communication goes, we can significantly reduce the chances by 4, 5, tenfold. I
Yeah,
think it's super important to do that.
I agree.
Um, but Dr. West, I definitely appreciate you coming on to kind of share your perspective as a physician, and just I am thankful that you're able to do this, just because I know how busy you are and everything like
Oh,
that.
thank you.
And I guess I'll probably see you. I think we have an appointment in 4 or 5 weeks or something like that.
All right, perfect.
For my like 3.5 month follow up.
All right, excellent.
Yeah, but thank you again, Dr. West, for just everything that you do from
Yeah, thank
physician and
you.
just what you're
No,
doing
thank
for
you
the
too.
field.
Thank
Cool.
you as well, Wesley. I mean, really, you're a true star too. So thank you.
Thank you, Dr. West. And I hope you guys enjoyed today's episode. Thank you for watching today's video. Please feel free to like and subscribe and share it on your social media platforms. If you're interested, I have started an ACL Mastermind group, which is a growing library of content centered around ACL rehab. It has exercises ranging from immediate post-op to late-stage sport-specific movements and everything in between. It's a growing library and currently holds over 250 videos. There's content centered around assessments, movement breakdowns, exercise breakdowns, case studies, and a whole lot more. You also gain access to a private forum where you can engage with like-minded people, ask questions, share research articles, and share resources. If you're interested, please feel free to click the link below. Thank you for watching.